This video is for educational and informational purposes only and should not be considered professional coding, medical, or legal advice. Welcome to Module 5, and this is the one where everything clicks into place. We've spent 4 modules learning how to code, assigning ICD-10 CM diagnosis codes, CPT procedure codes, and HCPCS Level 2 codes for supplies and equipment. But coding is only half of the revenue cycle. The second half is billing, taking those codes, packaging them into a claim, submitting that claim to the insurance company, and making sure the provider actually gets paid. That's what Module 5 is all about. Medical billing. The claim forms, the electronic submission process, and the document every biller lives by. The explanation of benefits, or EOB. If you're planning to sit for the CPC exam, billing concepts account for a meaningful portion of the test. And if you're going into practice, whether as a coder, a biller, or a revenue cycle specialist, understanding the full claim lifecycle is what separates a competent professional from a truly great one. Let's build that understanding right now. Here's our roadmap for Module 5. 6 tightly connected topics that walk you through the entire billing process from start to finish. Topic 1. The billing workflow. Before we get into specific forms, you need to understand the overall process. What happens between the patient leaving the office and the check arriving in the mail. Topic 2. The CMS 1500 claim form. This is the standard form for professional billing, used by physicians, clinicians, and outpatient providers. We'll walk through every key field on this form because you will see it on your exam and use it constantly in practice. Topic 3. The EOBs 04. This is the facility claim form used by hospitals and institutional providers. It's structurally very different from the CMS 1500, and understanding the distinction is important. Topic 4. Electronic claims and EDI, electronic data interchange. The vast majority of claims today are submitted electronically, and you need to know how that process works, what a clearinghouse does, and what 837P and 837 transactions are. Topic 5. Remittance advice and the EOB, explanation of benefits. This is what comes back after you submit a claim. We'll decode the payment, adjustment, and denial information, including the adjustment reason codes that appear on every remittance. And Topic 6. A complete claim walkthrough from encounter to payment. Let's go. Before we get into the specific forms, let me give you the full billing workflow, all 8 steps. Understanding the sequence helps you understand where each form, each process, and each document fits. Step 1. Patient registration and insurance verification. This happens before the patient is even seen. The front desk or billing staff verifies that the patient's insurance is active, checks benefits, confirms whether the visit requires prior authorization, and captures any deductible or copay information. If you skip this step and see a patient whose insurance is inactive, you may end up with an uncollectible claim. Step 2. Patient encounter and documentation. The provider sees the patient and documents the visit. This documentation, the chief complaint, history, exam findings, assessment, and plan, is the foundation everything else is built on. Garbage in, garbage out. Poor documentation leads to poor coding, leads to claim denials. Step 3. Medical coding. The coder reviews the documentation and assigns the appropriate ICD-10, CM, CPT, and HCPCS codes with all required modifiers. This is the work we've been learning in Modules 2 through 4. Step 4. Charge entry and claim creation. The biller enters the codes and charges into the practice management system, which generates the claim form, either a CMS 1500 for professional services or a EOB 04 for facility services. Step 5. Claim scrubbing and submission. The claim goes through a clearinghouse, a third-party electronic intermediary, which checks it for errors, missing fields, and code edit issues. Clean claims are transmitted to the payer electronically. Flagged claims are returned for correction, Step 6. Payer adjudication and remittance. The insurance company processes the claim, applies the patient's benefits, and generates a remittance, either an electronic remittance advice, or ERA, or a paper explanation of benefits, the EOB. Step 7. Payment posting and AR follow-up. The biller posts the payment to the patient's account, identifies any underpayments or denials, and works the accounts receivable to collect what's owed. Step 8. Patient billing and collections. Any remaining balance after insurance, copays, coinsurance, deductibles, is billed to the patient. Uncollected balances may eventually go to collections. 8 steps. Every clean claim follows this path. The CMS 1500 is the workhorse of professional billing. It's been the standard professional claim form since '92 and was most recently updated to version 02 to 12. Whether a claim is submitted on paper, which is rare today, or electronically, the data elements map directly from this form. The form has 33 numbered boxes, and they're divided into 2 logical sections. The top section, fields 1 through 13, captures patient and insurance information. Let me highlight the critical ones. Box 1 identifies the type of insurance being billed: Medicare, Medicaid, TRICARE, and so on. Box 1A is the patient's member ID number, exactly as it appears on their insurance card. Box 2 is the patient's name. Box 4 is the insured's name, which may be different if the patient is a dependent on someone else's policy. Box 11 is the insurance policy or group number. Boxes 12 and 13 are signature boxes. Box 12 authorizes the provider to release medical information to the payer. Without this, the payer can't process the claim. Box 13 authorizes the payer to pay the provider directly rather than sending the check to the patient. The bottom section, fields 14 through 33, captures the clinical and billing information. Box 17 is the referring provider's name and NPI, required when billing for referred services. Box 21 is where you list up to 12 diagnosis codes, labeled A through L. This is critical. The service lines are in Box 24. Box 24A is the date of service. Box 24B is the place of service code. 11 for office, office, 21 for inpatient, 22 for outpatient hospital. Box 24D is the CPT or HCPCS procedure code with up to 4 modifiers. Box 24E is the diagnosis pointer. This is a letter, A through L, that links each procedure line to its diagnosis. This field is mandatory and is frequently missing on rejected claims. Box 24F is the billed charge. Box 24G is units. Box 33 is the billing provider's information, including their NPI number. Knowing these boxes cold is essential for both your exam and real-world billing. Now let's talk about the UB04, the Uniform Billing Form, Form 04, which is used by hospitals, skilled nursing facilities, home health agencies, and other institutional providers. If you're going to be a CCS coder or work in a hospital setting, the UB04 is your claim form. If you're going CPC and working in a physician office or outpatient clinic, the CMS 1500 is primarily what you'll see. But every coder and biller should understand both. Let's look at the key differences side by side. Who uses it? CMS 1500 is for professional services, physicians, nurse practitioners, PAs, and outpatient providers. UB04 is for institutional services, hospitals, SNFs, home health. Procedure codes. Both forms use ICD-10-CM for diagnoses, but the procedure coding differs significantly. The CMS 1500 uses CPT and HCPCS codes as the primary procedure identifiers. The UB04 uses revenue codes, 4-digit codes that describe the type of service, combined with CPT or HCPCS codes where applicable. revenue codes are one of the most important concepts in facility billing. Code SO450 is the emergency room revenue code. 0360 is surgery, operating room. 0250 is pharmacy. Every single service line on a UB04 must have a revenue code. Without it, the claim cannot process. Diagnosis codes. The CMS 1500 holds up to 12 diagnosis codes. The UB04 holds up to 18 because hospital encounters often involve many more conditions than outpatient visits. Form complexity. The CMS 1500 has 33 numbered boxes. The UB04 has 86 form locators, FL for short. It also has condition codes in FL 18 through 28 that indicate special billing circumstances like coordination of benefits, and occurrence codes in FL 31 through 36 that document specific event dates like accident dates, surgery dates, or therapy start dates. The UB04 is more complex, but once you understand its logic, it's very navigable. Over 95% of claims in the United States are now submitted electronically. Paper claims still exist, mostly for very small practices or specific payer requirements. But the industry has overwhelmingly moved to electronic data interchange, or EDI. Let me walk you through the electronic claims pipeline from start to finish. It starts in the practice management system, the PMS. This is the software the practice uses to schedule patients, track encounters, and manage billing. When the biller enters charges, the PMS generates an electronic claim file. That file is formatted as an EDI transaction, specifically an 837 file. An 837P is the electronic equivalent of a CMS 1500. The P stands for professional, and 837I is the electronic equivalent of a UB04. The I stands for institutional. The 837 file is transmitted to a clearinghouse. Think of a clearinghouse as a translator and quality checker. Clearinghouses like Availity and Waystar receive claims from thousands of providers and translate them into the specific format each individual payer requires. They also run the claims through a scrubbing process, checking for missing fields, invalid codes, and formatting errors. Clean claims go through to the payer. Claims with errors are sent back to the biller for correction with an error report. The payer, United Healthcare, Blue Cross, Aetna, Medicare, receives the clean claim and runs it through adjudication. They apply the patient's benefits, check for coordination of benefits, and determine what gets paid. The payer sends back an 835 transaction, the Electronic Remittance Advice, or ERA. This contains all the payment details, the adjustments, and any denials. The other EDI transactions you need to know: 275, 271 for eligibility verification, 276, 277 for claim status inquiries, and 278 for prior authorization requests and responses. These transaction codes will appear on your certification exam. Know what each one does. After you submit a claim, the payer sends back an explanation of benefits, the EOB, or its electronic equivalent, the ERA. Reading this document accurately is one of the most critical skills for a medical biller. Let me walk you through the sample EOB on screen, because it illustrates 3 different outcomes you'll see every day. Line 1, CPT 992114, the office visit. The provider billed $185. The payer's allowed amount is $142. That's the contracted rate. A $30 copay was applied. The payer paid $112. The patient owes $30. This is a clean paid claim. No adjustment code is needed because everything processed normally. Line 2, CPT 85025, a complete blood count. The provider billed $42. The allowed amount is $28.50. There's no patient responsibility. The payer paid $28.50. The adjustment code is CO45. CO45 means charge exceeds the contracted rate. The difference between $42 billed and $28.50 unallowed, that $13.50, is written off. The provider cannot bill the patient for it. That's a contractual obligation adjustment. This is normal. It happens on virtually every claim from an in-network provider. Line 3. The J1100 dexamethasone injection. Billed at $18. Allowed amount, 0. Payer paid, 0. Patient responsibility, 0. Adjustment codes, CO4 and PR1. CO4 means the service isn't covered for this diagnosis. There's a code mismatch. Someone needs to go back to the documentation and verify whether the diagnosis supports this injection or whether the diagnosis pointer was entered incorrectly on the claim. PR1 means a deductible was applied, but the patient's deductible appears to have been met since the patient responsibility is 0. This is a denial. It goes into the denial queue for review. Now let me quickly explain the 3 adjustment prefix categories. CO, contractual obligation. These are payer-provider contract adjustments. The provider cannot bill the patient for CO amounts. PR, patient responsibility. These are billable to the patient. Deductibles, copays, coinsurance. OA, other adjustments. Various reasons that don't fit CO or PR categories. Knowing these codes is essential for denial management, which we'll cover in Module 7. Let's put everything from today together with a full claim walkthrough, from patient encounter to payment posting. Here's our scenario. Maria S., established patient, seen February 10th, 26, at Dr. Rivera's family medicine office. She has uncontrolled type 2 diabetes and hypertension. The doctor performs a moderate complexity EM and gives her a 4 mg IV dexamethasone injection. The practice bills Blue Cross PPO. Her copay is $35. Step 1. Which claim form? This is a physician office visit. Professional service. Place of service 11. We're using a CMS 1500. Step 2. Box 21. Diagnoses. We have 2. E11.65 in position A for the uncontrolled diabetes and I10 in position B for the hypertension. Step 3. Service lines in box 24. Line 1 is the EM 99214 with modifier to 25, because we're billing a separately identifiable EM on the same day as the injection. The diagnosis pointer links to both A and B. Both conditions were addressed. Line 2 is the injection J1100, 4 units, pointer A only. The injection was specifically for the diabetes management. Step 4. EDI transmission. The claim is generated as an 837p file, sent to the clearinghouse, scrubbed for errors, and transmitted to Blue Cross. Step 5. EOB Remittance. Blue Cross allows $140 for the 992NE and applies a $35 copay. The payer pays $107. For the J1100, the allowed amount is $8 total, 4 units at $2 each, and CO45 adjusts off the difference between what was billed and the contracted rate. Step 6. Payment posting. The biller posts the payment from Blue Cross to Maria's account and sends Maria a statement for her $30 copay. That is a complete claim cycle, from encounter to payment in 6 steps. This is the real world of medical billing. Excellent work! Let's lock in Module 5.1. The billing workflow is 8 steps, and every step matters. A breakdown at any point, bad insurance verification, poor documentation, incorrect coding, missing claim fields, can derail the entire claim. 2. Know your claim forms. CMS 1500 for professional services, UB 04 for facility and institutional services. They're different forms for different provider types with different fields and different complexity levels. 3. The diagnosis pointer in Box 24E links each procedure to the right diagnosis. Missing or incorrect diagnosis pointers are one of the most common causes of claim denial. Always double-check them. 4. 837P and 837I are the EDI formats for professional and institutional claims. You don't need to build these files yourself, but you absolutely need to know what they are. 5 clearinghouses are your first line of defense against rejections. They catch errors before the claim reaches the payer. Working with a good clearinghouse and addressing their error reports promptly keeps your clean claim rate high. 6. On the EOB, CO adjustments are write-offs. The provider absorbs them per the contract. PR adjustments are the patient's responsibility. They can be billed. This distinction is critical for knowing when you can balance bill a patient and when you cannot. For your Module 5 assignment, complete a blank CMS 1500 form using the Maria S. scenario from today's practice case. Identify common EOB denial codes and what action they require. And review the place of service code list, especially codes 11, 21, 22, 23, 31, and 32, because those appear frequently on the exam. Module 6 is next. Insurance types, Medicare, Medicaid, and coordination of benefits. We're going deeper into the payer side of the revenue cycle. See you there!